Give it just a minute more for individuals to join. And then we will begin our discussion. Doesn't look like many new people are joining, so maybe I'll just kick it off. All right, I'd like to welcome everyone to our quarterly meeting for HB 413 to walk through the items outlined in 413. I'd like to just begin by moving to our meeting minutes from our June 23rd meeting. And if there has been an opportunity for the committee members to review these, and if so, I'd love to take a motion on approving them.
Jim, this is Russ. I will motion to approve.
Thank you, Russ. Do we have a second?
I'll second. This is Adam.
Great. Thank you, Adam. Okay, all in favor?
Aye.
Aye.
Great. And any opposed? Okay, thank you. So that motion passes to approve the minutes from June 23rd. I'm going to stand up, at least introduce the UMIC contract updates and give a couple of us an opportunity to speak as we walk through this. So in our last meeting, we kind of closed that meeting with the next steps of where we were with our plans to discuss UMIC. And I wanted to just lay out first of all something that was addressed in the last meeting. We've been having many discussions in this setting, and then we've moved those into our UMIC meetings that happen every other week, that we've been discussing some of the elements that have been brought up here and some of the core items that we would like to see addressed in our UMIC contracts to both strengthen them and resolve some outstanding issues. One of the things that we've gone back to in this discussion is what are some of the what is the original intent of the UMIC contracts, and what are some of the items that we had discussed early on in the development of the UMIC contracts, and have we fulfilled those elements? One of the pieces and the reasons we've been working through this, as you know, has been our overall strategy was to look not only at the TAM population and moving that into an integrated model, but also consider the efficacy of our UMIC contracts today and see how they're performing, but also in the context of how our UMIC contracts are performing today, and hearing and getting feedback from both the behavioral health side as well as the ACOs, is to contemplate TAM integration, but also expansion of our UMIC contracts into our other ACO enrolled counties. And one of the things that we've been looking at in the context of these discussions is our timeline and what our intent is. So what I'd like to start with first is just to outline the conversations that we're having and what our overall strategy is at this point. In the context of our UMIC discussions that we've been having in last meeting, what was stated is that we were meeting with UBEC and working with them to make sure that the behavioral health providers were able to really clearly communicate with us some of their concerns, interests, desires in moving forward with these steps of UMIC expansion, current contracts with UMIC expansion, as well as TAM integration. And we've been having ongoing meeting with the directors. And then the second step that Brent and Nate and myself have undertaken is to meet with the other ACO enrolled counties to have conversations with them about some of the dialogue we've been having and introduce this idea of expanding UMIC into our other ACO enrolled counties. And so we wanted to cover that piece today. But in those discussions, we've also found that there are ongoing topics to address. So So with that, I think I'd first like to reflect the work that we've been doing as we've met with the counties and been able to have one-on-one dialogue with them and be able to get feedback. I wanted to bring some of the feedback here more generally, but also appreciate we haven't visited all the counties. We still have a couple counties to visit. After we're done with our with our visits to these areas, we want to meet individually with the ACOs and have a distinct discussion with them in that setting too. But through that, I thought that Brent would be able to first provide an update on who we visited with and just a general overview of those discussions, Brent, just to reflect that, and certainly invite others to speak up as well if you're here on the call. But I wanted to report back to this group what conversations have taken place and what general feedback we've received in those discussions.
Thanks, Jen. And like Jen has said, we've met with Weber Human Services, Southwest Behavioral Health, Bear River Mental Health, and Bear River Substance Abuse, Utah County in relation to their operation of services in Wasatch County, and Tooele County. And I think we still need to meet with Summit, and I believe we'll complete. But they've been interesting conversations. I would say at a high level, our county partners want to be good partners, and they recognize that this is, this has been the direction we've been heading. They did raise concerns, and many of the concerns have been the same themes that we've talked about here on these calls for a number of months. Issues related to prior authorization, credentialing, payment, turnover of staff, the need for additional administrative structure in terms of billing, and then sort of a general concern that the fee-for-service rates are not really sufficient for them to operate in the way that they do in another model. So I mean, those would be sort of the general themes that came up in most of those meetings. There were also some very interesting regional discussions. For example, when we met with Utah County, Utah County stepped in to deliver services in Wasatch County about 10 years ago when a county-operated program was falling apart. And I think there's always been, some concern from Utah County commissioners and others about whether this was the right role for Wasatch Behavioral Health to play. And they're very concerned that Utah County is not subsidizing Wasatch County. And so I think from Jurgen's perspective, if they're losing money in Wasatch County, it becomes more difficult for them to maintain a presence there and continue to serve the legacy clients. And so, as we talked to each of the counties, there were some unique differences that started to emerge. I would characterize that in some areas, I think we could probably make this happen. In other areas, there was significant pushback. In the Bear River area, for example, close to 20% of their total revenues at this point are related to Medicaid expansion, and losing that or not being able to bill for that may result in some damage to their bottom line that they were very concerned about. And then they also raised concerns around in a small rural area not having the administrative staff to manage relationships with 4 entities to get paid rather than one. So those were some of the more global concerns. I'd love to hear from this group what you're thinking about in terms of UMIC. And I feel like we've had some really good discussions in this call and in other calls recently about these issues. But so the discussion was really of no surprise. I think if we can get a handle on some of these processes that were the general themes, I do think we have, an opportunity to move forward. So are there questions about the county meetings? Oh, and then I also, the other thing, and Jen did say this in her comments, I think it's also really important that Nate and Jennifer and I also meet with the ACOs about each of these areas, and that we do that individually with you. Because I'm going to guess that some of you have concerns also about the way this is structured and what you want to do going forward. So we don't want to make this just so one-sided, but we would love to talk to you also about how do we resolve some of these issues that have been raised by the counties? Are these issues real? Are you interested in providing services in small rural counties that are going to, that's a difficult lift in some areas. And so are we really ready to do this? So we'd love to discuss this with you also. Emma, you had a question?
Well, I guess an observation. Anything and everything you just said is nothing new, I would just say. We've been having this discussion since the beginning almost of expansion. So I just want to say there's nothing new. It's the same issues over and over again. And so I'm not surprised by that feedback. And yes, I do think it would be good to meet with the ACOs individually or collectively. And I was hoping, because these issues continuously come up in the UMIC meetings, and up until recently, we really have not gotten down into the weeds or really developed a process for addressing the issues. So, one of the things we've talked about recently is we hear a lot about credentialing as a concern or prior authorizations, but we're at a stage where we just need to get down to the specifics. And talk about, well, what does that really mean? So personally, I look forward to actually finally trying to get down to talking about the specifics and trying to resolve the concerns, because I think there is so much, and the systems are so complicated. And for instance, one of the issues that was brought up the other day is with regards to credentialing. Is it really credentialing that's the issue, or is it just the submission of making sure that we're aware of every local authority's providers, which we have to know in order to make sure the claims get paid? And then there is the element of, are they really talking about just Medicaid, or is there some confusion about the requirements of commercial plans that the same entities operate, which have nothing to do with Medicaid, Absolutely. So I think we're at a point where we need to stop just talking about the issues and really start working towards what are the details, what are the facts, and what's the solution.
Oh, I agree with you. I think that the credentialing discussion, the issue that I keep coming up with or hearing is that the amount of time that it takes to go through credentialing and having staff that can't bill until they're credentialed, and the delays that it creates, and trying to support that staff without being reimbursed. And so expediting that process, I think, is really important.
And Brent, if I could just, and this is again where I think we need to stop talking at a high level and start getting down to details, because the department asked all the ACOs for their credentialing requirements, and for all intents and purposes, from what I understand, and I haven't seen all the information because it hasn't been shared with the ACOs, all of the information, but basically we're saying we don't ask for more credentialing. What we do ask for, which I think we can consolidate, is this list of providers so that we can load that into our system. So again, is it really credentialing? Is it the fact that not all 4 ACOs have the same format for the list? Again, we talk at this really high level, but it's like, well, let's not do that anymore. Let's talk about the specifics so we can actually try to fix the problem. Because I don't really know that it's a credentialing issue per se, unless they're also frustrated because they want to credential for the commercial products, and that we have no control. I mean, I shouldn't say we have no control over. That's not a Medicaid issue. I think this is what I'm saying.
No, I agree, and I think the issues on these calls were not surprising. They were not new in most cases. So I agree with that piece. We're mid-process. We still have some of these meetings to hold. And I also think it's important that we hear from the ACOs. And so while, ideally, we would have loved to have finished this process before this meeting so that we could get down to brass tacks.
Yeah. Thanks, Brent. And I will just say, we are discussing, we're going to have Becky report out here on our conversations that are happening in the UMIC meetings, and we are working on some of these issues. So I think we are making some progress in some areas and having active dialogue. So we'll get back to that when it's Becky's opportunity to present. Russ, would you like to comment?
Sure. I think, Brent, to your question around, the interest, I think the interest has always been there. From the ACOs, obviously can only speak for Select Health directly, but it's really a question too around just the time frame, right? So there does have to be an adequate time frame to implement. And so is there a time frame that we're looking at this point?
Our target date, Russ, is looking at July for next contract year. So for the FY25 contracts is what we're looking at. And so we're trying to work towards that, which is in our UMIC discussions, we've been actively wanting to address the credentialing issue, the timely payment issue, moving into the uniformity of prior authorizations. And so I think the timeframe Becky was looking at and we cited around credentialing was November 1 to finish up those discussions. We're in tandem bringing up utilization management and trying to get a survey of practices. And that's our next step, to look at that as well. If there are other big issues we're going to work on some of this behind the scenes individually with the ACOs. If there are unique issues that we need to work out around payment and support and things like that. But that's the process we're working. As you recall in our UMIC meeting several weeks ago, when Brandon presented, the two key issues that were brought up at that time were credentialing and utilization management. And those were the areas we've been focusing on and really would love to have cleared up close to the end of the year, if not by early January.
Okay. Yeah, thank you. And then, looking back through the document on metrics, I guess I would just reiterate that if there are metrics or additional contract language that need to be put in to make sure that that we're accountable to what we're committing to, right? I think everyone's in favor of that, because what that does for us, right, is it just spells out the cure that we've determined is necessary, right? And then we have it in the contract, and we know what we're working towards.
Yeah, that's precisely what we're thinking, Russ. So thank you for sharing that. Through these discussions, as we look at credentialing, for example, and we agree upon what the contract language will be as we work through that, what that process is, if it's process A or process B, and our options, option A, option B. And then also, agree upon what the contract language will be around uniformity of PA requirements. So,
yeah,
okay.
Great. Yeah, thank you.
Is there other feedback?
Is there anyone on from the counties who wants to speak to an issue that I missed? I don't see any of our county partners on the call.
I do have a question. Unless there's something else that's come up, the only prior authorization, I think that's what you're referring to, Jen, when you're talking utilization management, that is in the behavioral health world is just residential treatment. So just to be clear for those, I think everyone on this call knows that, but that just to be clear, that's the only one I'm aware of that it is, I guess, a concern. Is that correct?
That is not what we are told.
Okay.
So maybe the behavioral health providers would like to share what they're experiencing, but part of this survey would be to capture if there are other things outside of the residential piece. And
well,
I think
I definitely think we should do that, because just generally in Medicaid, we don't require PA for anything behavioral health other than just the residential treatment. And it's really just an informational PA at the beginning. And it's more of a provide medical necessity after the 60 days after the fact, right? Okay.
Yeah, I'll just share, as we're sharing feedback, there is a PA on psychological testing that plans are encountering.
Like, yeah, that's true. There is that too, but
Yep.
Okay.
So we will plan to conduct a survey of what's on PA for these services, and then I think walk into a discussion around not just what's on PA, but even the elements of the PA to establish what the uniformity standards mean. So I think that's an area we'd like to explore. So
and Jen, I think when we get down to the specifics, which again, I'm just encouraging because I just honestly feel bad for everybody who's involved in this process, who has been and continues to be, that the pandemic's definitely threw everyone off on some of these things, right? But I feel like we just need the opportunity to just sit down and figure it out. And as Russ said, I think we're all more than happy to have it spelled out in the contract. We just need to know just exactly what needs to be done, right?
Well,
And yeah.
and not to, I mean, we had this discussion internally, Emma, and it's the pandemic, it's the merger, it's PRISM, it's all of these things, it's the unwinding. We're working through those issues and we're getting them. And I know it's taking time.
Yeah, and again, I don't want to lose sight of the fact that unfortunately we have the federal partners too that are mandating some things, such as on the mental health side of residential treatment, if it's 1 day over 60 days, then they say they can pull all the federal funding, for the entire state. I mean, there are these things that I think people forget about when we're having these discussions because of the operational, I guess, struggle that we all deal with, like that's right in front of us. But I think we also need to discuss, when we have the details, why are some of those things in place? And then is there a better way to do that without also putting the state in some sort of jeopardy?
yeah, it's good. Thank you, Emma. Adam?
Yeah, so again, I think Emma's right. The residential is the only PA. I think from a provider perspective, it's not necessarily what's going wrong now. It's what is this going to look like in the future, and really solidifying that, so that one of the fears is that policies will be adopted that mirror commercial plans, and that just won't work for this population. Frankly, doesn't really work for the commercial patients either, but that's a discussion for a different table. But at the end of the day, like, acknowledging the population that we're serving and making sure that the benefit plan and works for who we're going to be serving, and that it is administratively feasible to do it from a provider perspective. And I think Emma's absolutely right. Let's figure out what those are in detail and agree to it, so that there's uniformity from the state and from the ACOs, and frankly the counties too, so that we can all be working from the same playbook and we all have the same understanding of who we're trying to serve. And so I guess the fears, at least from my perspective, are the unknown and what could be, and seeing what other states have done, which has decimated some behavioral health systems in other states. So yeah.
Adam, the policies that you're thinking primarily about are authorization for length of stay in a residential? Is that?
No, it's not just residential. It's all levels of care. If you look at, if we were to mirror a commercial plan, you're seeing lengths of stay in outpatient treatment, that you get 8 visits. Like, that's just not going to work. But having adequate dose for the treatment at the level of care that is required for that person is essential. So it's not just residential, it's all levels of care. And it's also medications, like prior authorization for the medications that we put people on, not like all of that is there. So it's not residential it's not residential centric.
Thanks, Adam. Go ahead, Becky.
So, and PA uniformity, I mean, obviously has far more to do with just what services PA is required for. There's all of those elements of when must it be requested, how many days are authorized at a time. And that's where I think we've strayed a little bit, where there's different requirements with the different plans versus what the fee-for-service requirements are. And I think that's caused some frustration with the providers, where, you know, one plan may authorize up to X number of days and another plan may only authorize up to, you know, a shorter number of days. I've heard from providers that's been some of the frustration.
Thanks, Becky. Go ahead, Nelson.
I just wanted to add that it hasn't just been residential. There have been requirements put on that were for things like psych testing by some of the ACOs. So I think it really does have to be in the contract what can be PA. And I think sometimes there might be some things that it's okay to have be different if that's what the state determines. But I do think that that has to be kind of a really narrow band and understood by all parties. And that has to just be written out in the contracts, because, you know, maybe someday Healthy U, I hope not, but maybe we'll get a kind of crazy idea and say, you know, this outpatient service has to get PA'd, and we'll throw a wrench into the works. And I don't want to do that. I think it just messes things up, and I don't want any of us really to have that option. So I think that's got to be kind of aggregated as a decision by the state and moved on. And so I think that that's just going to make it easier for everybody. But it hasn't just been residential that we're talking about, and I think it does kind of cause a lot of chaos.
Thanks, Nelson. Any other comments right now? Okay, thank you.
I guess my only comment is, again, let's just figure it out and get it in the contract.
Yep.
Because that could have been done in July. It could have been done, you know, I mean, could have are fine, but this really should not be this hard to figure it out. So I think we're just all willing to just sit down, figure it out, get it in the contract so everyone has some comfort. Because, you know, I don't think that it's anyone's intention to do what Nelson just said, to get too crazy, because ultimately we are still obligated for the most part to follow Medicaid's policy, and we do have some flexibility on UM. But I really think if we could just be specific, we could get it in the contract. I mean, we could get it in the contract amendments for January if we could just get down to the specifics.
Thanks, Emma. In the context of this, and knowing that the UMIC meetings have been working on uniformity or agreement in these two key areas that we've been discussing, I thought, Becky, is there anything additional that you want to share that's coming out of the UMIC meetings, or have we covered it in our discussion so far?
I think we've covered it. I mean, with credentialing, we've got some very specific things that we're working through, but I don't know that it's necessary to go through those things here. Unless people want to, but I think we've covered it already.
Thanks, Becky. And it sounds like we have agreement from the folks here on this call that we need to keep moving it forward, which we are. But I think maybe if November 1st is our timeline, by November 1st, we're going to have this done. And if January is our timeline for the prior auth items, let's just establish those timelines, work towards those goals, define what the contract language will look like, and move forward. It sounds like we're at this place that we just need to establish what our deadlines are and move into those deadlines. So we will commit to following up with the ACOs. We need one more conversation with Summit, like Brent mentioned. We will meet with the ACOs to debrief on these things. It can be a brief meeting, but we do want to have those conversations, and then we'll continue our working sessions in the UMIC group. We will bring this, as we committed last time, back to this meeting for a summary update next quarter. Okay, if there are no other individuals who want to share with regard to at least the UMIC contract discussions. The next item I just wanted to give a quick update on our justice involved waiver. There are no major updates to share, but I just want to keep this on this agenda as it certainly has become it's an area that will impact this group of individuals, some of these individuals we are talking about here, and wanted to just share where we are with our justice involved work. So let me just talk first of all, timelines with CMS, and then we'll talk about the work that we are doing on this. So CMS is the way that they're approaching our 1115 waivers is that we are working on them in bundles. And currently we are working on a bundle of 4 different waiver amendments with CMS that are in their final discussions. They do seem to be drawn out final discussions, but we are, I feel, running out of questions that they are asking us around our items of in vitro fertility amendment, oncofertility amendment, the UP increase that went through last session, and then the last piece is our medical respite amendment. I do want to touch briefly on medical respite for this group, just a minute or two, that this was a benefit that is designed for our TAM population who qualifies as homeless or at risk for homelessness, this individual would be discharged from an inpatient setting and meet home health level of care requirements. This would provide, this medical respite benefit would provide up to 40 days per rolling calendar year. They do not need to be continuous days if there are multiple admissions and discharges, but up to 40 days maximum of medical respite covered services, which include housing and food and home health nursing support for an individual that meets this criteria. The way that we would implement this policy is by putting out an RFP. This was designed to be one location, one pilot site to serve individuals who would qualify. So we are going to put up an RFP for a contract with a program that can support this service for this group. So we do feel that these conversations are coming to an end with CMS, at which point we have worked through next steps of what they would like to discuss with us. We have already walked into justice with them and early discussions. As you know, 3 years ago, we did submit a justice waiver to CMS. Following the release of the state Medicaid director letter on justice involved work for Medicaid enrollees, the state Medicaid director outlined different elements than we had originally envisioned. And so we've been in discussions with CMS about what our original plan looks like and what their current framework looks like, and where we are on updating our intent on meeting those requirements. We will talk about this as soon as CMS finalizes the 4 waivers. They will approve all 4 waivers at the same time, at which point our next discussion will be to move into justice and other amendments that we have submitted. We have been working, so that's the timeline. I also want to put into context that there now have been a few states that have been approved for their justice waivers. I think our readiness, our approval in this waiver really comes down from CMS to our readiness. And I don't know the exact timeline, but I do know this will be many months of discussion with CMS, as these waivers often are. But they are very interested in working with us to facilitate this process. We're looking at, best option, maybe 6 months, a year. But some of the things, even with approval, really depends. What we see right now is that the facilities themselves are ready to be able to do and support this work. We feel that our work internally is pretty well defined with regard to the policies. We're working on system programming around benefit plan design and some of the systems work we need on our end to operationalize this. But as we've worked with at least the prison and our own team internally on what is needed, both for JJYS and our own prison that works on the same system. There's a significant amount of interface design that not just interface design, but design of their own programs to support the documentation requirements and the medical care plan for both mental health SUD as well as physical health care services to support care plan development. And then the billing aspect is another piece. We're hoping to meet with the county jails as well very soon and lay out what these requirements look like, knowing that it may take several months to really lay out what the requirements are, and then also build in that programming timeframe. But we know that this is something that's important to, and we've been dialoguing more internally around this with our own teams within DHHS as correctional healthcare has now come under the DHHS umbrella, at least from the prison. And we've been able to talk about this internally, but we're also ready at that point to start talking with the counties or with the county jail systems as well. So wanted to just bring that up as where we are with that and share that. I don't know if there's any additional questions about this, but that is what we have to share at this time.
Sorry, Jen, I just have a question.
Go ahead.
And
Sure.
since others are on the call, I mean, there has been discussion over the years about creating a central database to connect all of criminal justice. And I think that was being led by CCJJ. Is that correct? I'm just trying to find out if this is going anywhere, because to me, this is a really critical piece of this justice involved waiver.
Yeah, I know, Emma, I had asked you at one point, who led that project? Because we were trying to track down, right? Like the legislative stakeholders and then where that development was and where we are today. We've not had those discussions. I'm so sorry, my dog's barking, but we have not had those discussions yet at this point yet.
Yeah, I was just wondering if anybody else on the call as well had any insight into that. Doesn't sound like it at this point. So yeah, that is a big piece though.
I haven't heard any updates or any progress on that. It may be moving forward, but we can check in with CCJJ.
Okay, thanks, Nate.
Okay, with that, I think we can move to the next item and just move into Q&A. If there are any questions, we can certainly take those at this time. Okay, with no questions, I think we can close our meeting today just a few minutes early. I want to thank you all for joining our call today and engaging in discussion with us about these topics. I hope you have a nice weekend.
Thank you.
Thanks, Jen.
Thank you.